Hello. Today we're going to be talking about alterations in gastrointestinal function, specifically nutrition, ingestion, digestion, absorption, and elimination. So alterations in GI function, fluid and electrolytes. Remember, the newborn weight is 75% water. This decreases to approximately 45% in late adolescence. Newborns have more extracellular than intracellular fluid. The opposite is true for children and adults. Children under 2 years of age, their kidneys are immature, so they may become dehydrated and develop fluid and electrolyte imbalances more easily. So there is a formula that can be used to calculate the daily maintenance fluid requirements. This is based on how much the child weighs in kilograms. So for a body weight of 1 to 10 kilograms, the amount of fluid per day would be 100 milliliters per kilogram in a 24-hour period of time. For 11 to 20 kilograms, you will use 1,000 milliliters plus 50 milliliters per kilogram for each kilogram more than 10 kilograms. And then for the child that is more than 20 kilograms, you would use 1,500, 1,500 milliliters plus 20 milliliters per kilogram for each kilogram over 20 kilograms. So dehydration, isotonic dehydration is the most common type of dehydration that we find in children. The earliest detectable sign is usually tachycardia. One of the most important determinants of the extent of dehydration is body weight. So please note in your textbook, there's table 22-3 and 22-4 that address the signs and symptoms of dehydration. So mild dehydration, we're going to see weight loss. So in an infant, it would be 3 to 5%. In a child, it would be about 3 to 4%. The pulse is normal, blood pressure is normal, behavior is normal. They might be slightly thirsty. Mucous membranes are normal. The tears are present. Remember, infants don't develop tears until they're about 2 to 3 months of age. Anterior fontanelle is normal. Jugular vein is visible when supine. And skin, basically the capillary refill may be greater than 2 seconds. Specific gravity may be greater than 1.020. Moderate dehydration, weight loss, infants about 6 to 9%, weight loss in children 6 to 8%, pulse slightly increased, blood pressure, they might have orthostatic hypotension, so you might see a change greater than 10 millimeters of mercury. Behavior, they are irritable, they're a bit more thirsty, the mucous membranes may be dry, tears would be decreased, anterior fontanelle may be normal to sunken, the external jugular vein may not be visible except with supraclavicular pressure. Skin, you will have a decrease in the turgor, and then the specific gravity may be greater than 1.020, and they may be oliguric. For severe dehydration, the weight loss in infants is usually more than or equal to 10%, and in children it would be more than 10%. The pulse increased, blood pressure, they can be orthostatic hypotensive or shock. Behavior, they can be very irritable, and then they might actually even be becoming more lethargic. They may be extremely thirsty. Their mucous membranes are parched, tears can be absent, anterior fontanelle may be sunken. The external jugular vein may not be visible even with the pressure. Skin may be, they may have significant tinting. The skin may be cool, they may be acrocyanotic or mottled. The urine-specific gravity, they may be oliguric or anuric. And so here are actually the tables that are in your textbook. So I'm not going to read the entire table. I actually did go over quite a bit of this stuff. So please feel free to read this in your text. And then you'll notice that there is some a little bit of differences for the clinical manifestations of dehydration, dependent on the tonicity. So is it hypotonic, isotonic, or hypertonic? So diagnostic behavior, I'm sorry, diagnostic evaluation, um, basically, in order to initiate the therapeutic plan, many things need to be determined. The degree of dehydration based on physical assessment, the type of dehydration based on the pathophysiologic of the specific illness responsible for the dehydrated state, specific physical signs other than the general signs, the initial plasma sodium concentrations, serum bicarbonate concentration, and then any other associated electrolyte and acid-base imbalances. And especially when we're talking about electrolytes, we want to pay close attention to that serum potassium level. So medical treatment, oral rehydration therapy with Pedialyte, breastfeeding can continue. Oral rehydration management consists of replacement of fluid loss over a 4 to 6 hour period, replacement of continuing losses, and provision for maintenance fluid requirements. In general, the mildly dehydrated child may be given 50 milliliters per kilogram of oral rehydration solution, whereas the child with moderate dehydration may be given 100 milliliters per kilogram of oral rehydration solution. The child with fluid losses from diarrhea may be given an additional 10 milliliters per kilogram for each stool. Note, in order to make it easier for kids to take more fluids, you can freeze them so that it's almost like they're eating popsicles. Replacement fluids must be given in addition to the maintenance fluids when dehydrated. Initial IV therapy for severe dehydration is typically 20 milliliters per kilogram over 5 to 20 minutes, and we repeat this based on our assessment. Then we want to replace the deficits to catch up the losses. And then finally, we want to return the child to oral food and fluids, but please note that they may still require IV therapy. If the child has an isotonic or a hypotonic dehydration, you want to give the first half of the replacement over 8 hours and then the rest over 16 hours. If they have a hypertonic dehydration, we want to give the replacement fluid over 48 hours. Replacement fluid and maintenance fluids are given simultaneously. In order to diagnose the type of dehydration, we're going to look at the sodium. So hypotonic, the sodium is less than 130. Isotonic, sodium is 130 to 150. And hypertonic, the sodium would be greater than 150. As a nurse, we need to monitor vital signs, INO, weight. And as I mentioned earlier, weight loss is the most reliable indicator for dehydration in kids. We want to look at skin turgor, level of consciousness, postural hypotension, fontanelles, capillary refill, monitor the lung sounds during rehydration so we can pay attention if the child is developing fluid overload. And please remember, before starting potassium-containing fluids, make sure that the patient has adequate urine output, approximately 1 to 2 milliliters per kilogram an hour. Let parents know they need to seek medical attention if the child is vomiting and not tolerating oral rehydration therapy after a 4-hour period of time. You don't want to give them diet drinks because they do need some sugar to to facilitate the absorption of sodium, or full-strength Jell-O soft drinks or juices because this can actually increase diarrhea. You want to avoid caffeinated beverages because these are mild diuretics. Chicken or beef broth is not given because it contains excessive sodium and it's inadequate in carbohydrates. Diarrhea. This is a leading cause of illness in children less than 5 years of age. In the United States, children under 5 still die from diarrhea and dehydration. There are different types of diarrhea, and here we can see acute, chronic, intractable in infancy, and then chronic nonspecific in the 6-month-old to 54-month-old. Signs and symptoms, in general, it's an increase in number, and more liquid stool. They can also have cramping, irritability. They are hard to console. They may have nausea, vomiting, and anorexia. Diagnosis. You want to get a thorough history from parents, including travel history and daycare. Check the stool for ova and parasite infection. C. diff if they've been recently on antibiotics. Uh, Assess for viruses. Rotavirus is the most important cause of dehydrating diarrhea in the world and does require contact isolation. And we also want to do a complete metabolic panel. Remember, it is best to prevent this, and this can be done with good hygiene, being careful when traveling, good hand washing, and vaccines, specifically the rotavirus vaccine. Treatment, we want to correct fluid and electrolyte imbalances and dehydration. If they are severe, they may be hospitalized and they may be given an IV. They also might be placed NPO. Remember that IV fluids with potassium must be given only in the presence of adequate urine output. I know I'm repeating that, but that is something that is very important to remember. As a nurse, monitoring the vital signs, checking the stool for the number, amount, color, odor, consistency, monitoring for occult blood, ova and parasites, and rotavirus. Contact isolation should take place until we know the cause. We want to assess a daily weight, INO, limit solid foods to allow the bowel to rest. We want to assess for the signs and symptoms of dehydration. Make sure that we change the diaper frequently. Gently wash after each stool. Apply A&D ointment, zinc oxide, or Vaseline as a barrier. You can leave the diaper open to air as appropriate. Once they are rehydrated, infants may be given breast milk or formula. Toddlers a soft puree diet. Children can have an easy to digest regular diet. You want to slowly resume their normal diet. The brat diet should be avoided because of poor nutritional content. Some children will actually tolerate a regular diet once they are rehydrated. Hirschsprung's disease. This is also called congenital aganglionic megacolon. And this is basically an absence of ganglion cells in one or more segments of the colon that results in the absence of propulsive movements. And that causes an accumulation of intestinal contents and distension of the bowel proximal to the defect. Diagnosis, this is based on history, bowel pattern. The diagnosis is confirmed with a biopsy that shows an absence of the ganglion cells. In box 22.2, you will see the different signs and symptoms. So for the newborn, failure to pass meconium within 24 to 48 hours after birth, reluctance to ingest fluids, bile-stained vomitus, abdominal distension. In infancy, you would see failure to thrive, constipation, abdominal distension, episodes of diarrhea and vomiting. Ominous signs often signify the presence of enterocolitis, which is a leading cause of death. Here you would see explosive, watery diarrhea, fever. This child appears significantly ill. In childhood, you could see constipation, ribbon-like foul-smelling stools, abdominal distension, visible peristalsis. Fecal masses are easily palpable, and the child usually looks poorly nourished and anemic. Preoperatively, we're going to be monitoring their fluid and electrolytes, vital signs, replace the fluid and electrolytes as appropriate, monitor, excuse me, for signs and symptoms of bowel preparation, like fever, increasing abdominal distension, increasing abdominal discomfort, vomiting, abdominal tenderness, irritability. They also might have shortness of breath and cyanosis. Symptomatic treatment with isotonic enemas, a low fiber, high calorie, high protein diet, and in severe situation, they may use TPN. Use of isotonic enemas may be necessary in children. If it's a mild defect, this might be able to be managed by using dietary modifications, stool softeners, isotonic colon, irrigations to prevent impaction. If they require surgery, typically what will happen is they will do a surgical removal of the aganglionic colon, a temporary colostomy, and then reanastomosis may occur when the child is about 20 pounds. As a nurse postoperatively, we're going to be monitoring vital signs, intake and output, hemorrhage, pain, abdominal distension, bowel sounds. We want to monitor for diarrhea and an infection a little bit later. Teach parents ostomy care. Meticulous skin care is crucial in the patient that has an ostomy. You want to use skin prep or paste, monitor the stools, and ensure the patient is having regular bowel movements. Appendicitis. So this is an inflammation of the variform appendix, usually from an obstruction in the appendiceal lumen. This can be due to a fecal lith, which is a hard fecal mass, intestinal parasites, anatomical defects, and possibly a low fiber diet. It's slightly more in boys and girls, and the peak age is between 12 and 18 years of age. Signs and symptoms. Typically, the first symptoms that you might see would be a colicky, cramping, abdominal pain located around the umbilicus. The pain then may shift to the right lower quadrant, which is called McBurney's point, and this is located 2/3 the distance along the line between the umbilicus and then the anterior superior iliac spine. This is the most common point of tenderness. Other clinical manifestations include, as I mentioned, the right lower quadrant of abdominal pain, fever, a rigid abdomen, decrease or absent bowel sounds, vomiting. This typically follows the onset of pain, constipation or diarrhea, anorexia, tachycardia, rapid shallow breathing, pallor, lethargy, irritability, and a stooped posture. If the pain suddenly stops, it's most likely means that the appendix has popped. Subsequently, there will be an increase in pain, which is usually diffuse and accompanied by a rigid guarding of the abdomen. Then you will see a progressive abdominal distension, tachycardia, rapid shallow breathing, and as a child will then start to refrain from using the abdominal muscles. They may be pale, chills, irritability, and restless. Diagnosis. It's difficult. The cardinal sign is abrupt onset of abdominal pain, elevated white cells count, usually over 10,000. C-reactive protein is typically elevated, and ultrasound is a diagnostic tool of choice. A CT is also often done. About half of adolescents with appendicitis did not look sick to the examiner in one study. So you do need to be suspicious even if the child doesn't look that sick. So treatment, basically, they're gonna surgically remove the appendix. Ideally, this is done before it perforates. Typically, the surgery is a laparoscopic surgery. This involves 3 small incisions, or they can also do a regular open appendectomy, which involves just 1 incision. If you think a patient has appendicitis, place them NPO. You want to, if it's ruptured, and we know that it's ruptured, place them in a semifallus position so that the drainage can drain downward rather than upward towards the lungs. They will need to have an IV in place. They'll be given antibiotics. They may have a nasogastric tube in place if it's ruptured to low suction until the bowel sounds return. Typically, they will be on antibiotics from 7 to 10 days. They may have a drain once they've had surgery, so they could have a Penrose or Jackson Pat drain. Also, the wound may be left open. If it's ruptured, they may do saline dressings. You want to position them with the head of the bed elevated or on their right side to facilitate drainage. Usually they can eat once the bowel sounds are present. Typically we start with clear liquids and then we progress very slowly as tolerated. For pain management, typically the first couple of days there will be IV narcotics, and then afterwards they will be given oral narcotics and then slowly decreasing to non-opioid medications. They should be using an incentive spirometer 10 times an hour while awake, and they do ambulate the very first day. You don't want to use a heating pad, laxatives, or enemas if you expect somebody has appendicitis, because this can increase inflammation and stimulate motility, and then this can increase the risk for perforation. You can use cold packs or ice packs. In your text, there is an unfolding case study, so you may want to complete that. Crohn's disease. So this is a chronic inflammatory bowel disease that can occur anywhere in the GI tract. It most often occurs in the terminal ileum. The lesions are segmented and transmural. That basically means that they can go through the mucosal wall. They may develop enteric fistulas between loops of the bowel or nearby organs. Ulcers may grow in size and depth, and submucosal inflammation can be severe. The cause is unknown, but it is most often seen in Caucasians and Jewish people between 15 and 25 years of age. The signs and symptoms: abdominal pain, cramps, diarrhea is moderate to severe, severe weight loss, fever, severe anorexia, rectal bleeding is uncommon, anal fissures or fistulas and significantly poor growth can occur. Mild rash and joint pain may be mild to moderate. Diagnosis: history and physical, elevated white blood cell count, ESR with exacerbation will be elevated, anemia, low total protein, albumin, iron, zinc, magnesium, vitamin B12, and fat-soluble vitamins. So these all may be low. Upper GI with a small bowel follow through to evaluate the small bowel disease. Endoscopy with biopsy may be done to determine the extent and the severity of the inflammatory process. A colonoscopy can confirm the diagnosis and evaluate the extent of the disease. Treatment. So here they can use 5-aminosalicylates. These are the first line of treatment. They inhibit the prostaglandin synthesis. These are active in the colon only. Some examples are mesalamine, osalazine, balsalazide. These are preferred over the sulfasalazine due to less side effects. Some side effects do include headache, nausea, vomiting, and neutropenia. Please note that these can interfere with folic acid absorption, so you want to give folic acid supplements. Corticosteroids, these are indicated in induction therapy in children with moderate to severe ulcerative colitis and Crohn's disease. These drugs inhibit the production of adhesion molecules, cytokines, and leukotrienes. It's not commonly used for maintenance therapy because of their long-term side effects, including growth suppression and adrenal suppression. Weight gain and decreased bone density can occur. You do want to monitor for side effects of corticosteroids. Metronidazole is used adjunctively. Immune modulators, azathioprine and 6-MP can be used for kids who are steroid resistant. Some side effects here include infection, pancreatitis, hepatitis, bone marrow toxicity, arthralgia, and malignancy. Biologic therapies help to regulate inflammatory and anti-inflammatory cytokines. TNF-alpha, Remicade, which is infliximab, is used for severe disease resistant to other therapies. It is needed every 8 weeks and may need to be, the patient may need to be pre-medicated with prednisone and Benadryl prior to being given that medication. Some severe side effects include lupus-like syndrome or lymphoma. Less serious effects include stuffy nose, sinus pain, stomach pain, mild skin rash, or headache. Humira, which is also called adalimumab, is approved for children over 4 years of age. TB and other opportunistic infections have been seen in people on Humira. Surgery may be done. Typically, it's just resections for obstructions or fistulas, but surgery is not curable. Nutrition. They will be on a high protein, high carbohydrate, high calorie, regular fat, small frequent meals. They will be on vitamin B supplements, general vitamin supplements, B complex, iron, and zinc supplements. TP, excuse me, TPN may be needed. Special enteral formulas given either by mouth or continuous nasogastric infusion, typically this would be done at night, may be required. We do want to encourage socialization during meals. They must take their medications even when there are no symptoms. Because of the long-term steroid use, there may be growth retardation and sexual development delay. We want to weigh these children daily. We want to avoid gas-producing foods and fluids, count the number of stools a day, use antidiarrheals and antispasmodics as needed. They are at a high risk for bowel cancer, therefore regular screening and early detection is going to be necessary. Parents need to learn how to use a central venous catheter line because often, as I mentioned before, these children will be on TPN, so parents will need to know how to manage a central line. Signs and symptoms of infection, malfunction, and TPN tolerance all need to be taught to the parent. If they are an NG tube feeding, make sure, again, the parents know how to do the procedure. Patients need peer support groups because of changes in their appearance. They are often sick and in and out of school. Dietary restrictions and the inability to compete with peers can all be very problematic and disruptive to the child. So it is important that they join a peer support group. Ulcerative colitis, another inflammatory bowel condition. This is an inflammation of the colon and rectum and the mucosa and the submucosa. It may be mild, moderate, or severe. Signs and symptoms are rectal bleeding is common, severe diarrhea, less frequently is abdominal pain that worsens with defecation, anorexia, mild to moderate weight loss, mild rash, and a mild to moderate joint pain with mild growth problems. Diagnosis, history and physical, CBC, ESR is elevated, upper and lower GI and endoscopy confirms the inflammatory bowel disease. Medical treatment and nursing care are similar to Crohn's disease. They have less problems with growth failure. If medical and nutritional treatment is not sufficient, surgery is curative. A colectomy with a rectal mucosectomy, an endorectal ilioanal pull-through, and an anastomosis with a pouch created to increase continence after surgery is considered curative. Surgery also prevents cancer in the patient with ulcerative colitis, and then their risk is the same as that of the rest of the population. People with Crohn's and ulcerative colitis should get colonoscopies with a biopsy 7 to 10 years after diagnosis, and then every 1 to 2 years after that, unless the patient with ulcerative colitis had the corrective surgery. Overall, nursing management includes continued guidance of the families in terms of managing their diet, coping with factors that increase stress and emotional lability, adjusting to a disease that has remissions and exacerbations, when indicated, preparing the child and the parents for the possibility of diversionary bowel surgery. Next, we're going to talk about cleft lip and cleft palate. So this is not in your GI chapter. It is in chapter 8, beginning on page 218. So cleft lip and cleft palate, this is basically an incomplete fusion of the lip or palate or both. It can be unilateral, so it can be on one side or both sides. Folic acid at the time of conception can decrease the risk by 25 to 50%. Cleft lip. Basically, this is usually repaired anywhere from 2 to 3 months of age. Many doctors will follow the rule of 10s, so they want the infant to be 10 weeks old weigh about 10 pounds, and have a hemoglobin of 10. A Logan's bow or other stabilizing dressing is used to prevent tension on the suture line. The child is medicated to decrease crying, and the elbows are kept restrained. Cleft palate, typically repaired before 12 months of age, does depend on the surgeon. This does protect the formation of tooth buds and promotes a more normal speech development. Before a cleft palate repair, the child must be weaned and taught to drink from a cup. They cannot have straws, pacifiers, bottles, or metal utensils because these cannot be used immediately after surgery for at least 7 to 10 days. They also are not allowed to brush their teeth for 1 to 2 weeks. So these children also have an increased risk for otitis media, and frequent otitis media can affect speech and hearing development. The reason they have this is because they have a poor middle ear drainage due to the inefficient functioning of the eustachian tube. So pre-op, they do have a risk for aspiration, so we want to monitor their respiratory status, vital signs. You want to feed them slowly and do please meet their sucking needs. You want to use adaptive devices like a cleft lip nook or Playtex nurser. They also have a cleft palate special needs feeder, a pigeon bottle, a Mead Johnson cleft palate nurser. A syringe also may be used if these are not successful. You want to excuse me, you want to position the child very upright when you are feeding them, and then burp them after every 15 to 30 milliliters. You want to keep suction equipment at the bedside in the event of aspiration. Altered nutrition, so we want to monitor their fluid and caloric intake daily. Daily weights, they should have roughly 100 to 150 calories per kilogram a day, and then 100 to 130 milliliters per kilogram a day. They may be able to be breastfed in a semi-sitting position initially. It would be important for the mother to elicit the let-down reflex prior to nursing, and this can be done by applying a warm cloth to the breast prior to feeding. And then all you have to do is you can just, if they just have a cleft lip, you can just plug the cleft lip, you can just pinch it closed. Often the lip will mold to the breast. If they are not successful, you can just have the mom pump, excuse me, have the mom pump the breast, and then you can bottle feed or do whatever kind of adaptive feeding of the breast milk. Also contacting the La Leche League because they may be able to be of assistance. They may need to have a nasogastric tube feeding if they're unable to meet adequate nutrition. So the ESSR method of bottle feeding, so this is not in your textbook, but it is important to know. Basically, ESSR stands for you want to enlarge the nipple, stimulate the child to eat, wait for them to swallow, and allow them to rest. Postoperatively, so here we need to monitor for ineffective breathing, check vital signs, assess their respiratory status. We want to keep suctioning at the bedside. They may be in a cool mist tent for the first 24 hours after surgery. Typically, they will be positioned supine and upright for cleft lip. We don't want them rubbing their lips, so they should be have their elbows in elbow restraints. The position for somebody that has cleft palate is typically on the stomach. That way, if there's any drainage, they don't aspirate it. That's initially, and then they would be placed upright. As I mentioned before, elbow restraints, no metal utensils or straws, keep them well pain medicated, encourage parents to hold and comfort the child, and then let the child play with appropriate toys. The parents may remove the elbow restraints if they are holding the child and make absolutely certain that the child is not going to touch their surgical sites. So they may hold their arms without the elbow restraints, but the minute that they are not holding their arms, they do need to put the elbow restraints back on. Again, always monitoring for infection anytime somebody has surgery. It's also, you will see that they will have the suture site cleaned basically with just like a little bit of normal saline. They may apply an antibiotic ointment if ordered, or petrolatum jelly for the first 7 to 10 days. Nutrition, they may be fed with a dropper or aseptic syringe, and typically they are given high calorie soft foods. Parents need to be taught all the home care for feeding, positioning, and follow-up care with the physicians. Hypertrophic pyloric stenosis. So this is basically an obstruction of the circular muscle of the pyloric channel. The circular muscle of the pylorus becomes thickened, causing constriction of the pylorus and obstruction of the gastric outlet. This generally develops the first few weeks of life. So initially, they are a very good eater. Vomiting occurs usually 30 to 60 minutes after eating. As obstruction progresses, they can actually develop projectile vomiting up to 3 to 4 feet. They are very irritable, they have failure to thrive, weight loss, dehydration, and they are hungry after they have vomited. Diagnosis, peristaltic waves across the abdomen going from left to right. They have an olive-sized mass on the right upper quadrant of the abdomen. An ultrasonography will demonstrate an elongated mass surrounding a long pyloric canal. And an upper GI series to rule out other causes of vomiting. Preoperatively, they're going to be NPO, they'll be on IV fluids and an NG tube to intermittent suction. The treatment is a laparoscopic surgery. It is a pyloromyotomy. This is also called a Fredette-Ramstead procedure. And basically what it does is it releases the muscle fibers so that the food and fluid can pass. So basically they're just snipping the little circular muscle fibers, and that causes the area to open up so then food and fluid can go through. Post-operatively, obviously we're always monitoring vital signs, hemorrhage, IV fluids, bowel sounds, strict INO, weight loss. A couple of days later, we're monitoring for infection. Usually they're going to start their diet typically with a clear liquid within the first 4 to 6 hours once bowel sounds are present, and then they will follow the prescribed amount and fluid progression. It's not uncommon for the child to still have some vomiting 24 to 48 hours after surgery. Once they are tolerating full feedings, the patient then will be able to go home. This usually takes about 2 to 3 days. Intussusception. This is where one portion of the intestine telescopes into another. It typically begins at the ileocecal valve into the cecum and colon. This is more often in boys between 5 months and 3 years of age. It's most common under the 2 years of age. In box 22.8, here you can see the signs, the clinical manifestations. So typically you're going to see a sudden acute abdominal pain. The child will be screaming and draw their knees up onto their chest. The child will look normal and comfortable in between episodes of that pain. So it is sort of an intermittent. They can have vomiting, lethargy, passage of red currant jelly-like stools, and this is stool that's mixed with blood and mucus. They can have a tender distended abdomen, palpable sausage-shaped mass in the right upper quadrant, an empty lower right quadrant, which is dance sign. Eventual fever, prostration, and other signs of peritonitis may develop. Chronic signs and symptoms would include diarrhea, anorexia, weight loss, occasional vomiting, and pain. Based on the history, a definitive diagnosis is based on the ultrasonography that reveals a characteristic heterogeneous mass and a bull's eye. In most cases, the initial treatment of radiologist-guided pneumoenema or a gas enema or an ultrasound-guided hydrostatic enema The advantage of the latter being that no ionizing radiation is needed. If surgery is indicated, the intestine will be reduced and the necrotic tissue will be removed. So the nurse should monitor for a passage of brown stool. This indicates the intussusception has reduced itself and should call the practitioner. Post-operatively, basically the care doesn't differ from that of any other child undergoing abdominal surgery. So vital signs, hemorrhage, bowel sound checks, respiratory checks, monitoring the abdomen for distension. They may have a nasogastric tube to intermittent suction, monitor stool patterns, the wound site for signs and symptoms of infection, as well as bleeding, as I mentioned before. And typically they will start with clear liquids and progress to full feedings as tolerated. Celiac disease. This is a gluten-induced enteropathy. This is a disease of the proximal small intestine characterized by abnormal mucosa and a permanent intolerance to gluten. This is actually the second most common malabsorption problem in children. Cystic fibrosis is number one. When the patient eats wheat, barley, rye, and oat-containing foods, the gliadin part of the gluten is not digested, resulting in an accumulation of a toxic substance that damages the mucosal cells. GI changes cause malabsorption of protein, carbohydrates, calcium, iron, folate, and then the fat-soluble vitamins, vitamin A, D, E, and K, as well as vitamin B12. So initially, the signs and symptoms, typically they appear between 1 and 5 years of age. They have impaired fat absorption. So the stools are stetoritic. They are excessively large, pale, oily, and frothy. They are very foul smelling. They have an impaired absorption of nutrients, so they have malnutrition, muscle wasting, which is especially prominent in the legs and the buttocks, anemia, anorexia, abdominal distension. Behavioral changes may occur like irritability, fretfulness, uncooperativeness, and apathy. Celiac crisis includes an acute severe episodes of profuse watery diarrhea and vomiting. It may be precipitated by infections, especially gastrointestinal infections, prolonged fluid and electrolyte depletion, and emotional disturbances. If this is diagnosed late, they may develop problems with dentition and bone density. Remember, we said that this can cause a malabsorption of the calcium as well as vitamin D, and these are all very important in terms of bone development. Diagnosis: a blood test for transglutaminase and anti-endomysial antibodies in children greater than or equal to 18 months of age. A biopsy of the small intestine shows mucosal inflammatory changes, fecal fat content, and full clinical remission after gluten withdrawal from the diet. Children with untreated celiac disease may have lactose intolerance, but this usually resolves after treatment. So what is the treatment? Basically, we need to eliminate all gluten-containing foods. So we need to make sure the parents understand they need to read all the labels. So cereals, baked good, processed ice creams, lunch meats, hot dogs. And I know you're probably going, well, hot dogs are meat. Sometimes they have fillers, which are, it's almost like a breading, and that contains gluten. Gravy, prepared soups, prepared hamburgers, some chocolate candies. So you really, it's critical that these parents read the labels on everything they feed their children. You can't substitute things like corn, rice, and millet. There are many cookbooks out there that will help a parent to maintain a low to no gluten diet. Prognosis: the signs and symptoms significantly improve within just a few days to a few weeks from a low to no gluten diet. The mucosa is often better after 6 months of treatment. The thing is that the most serious complication of this disease is getting lymphoma if you are not compliant. So it really is important to be compliant. Most kids, they are healthy and symptom-free if they are compliant. So again, compliance is critical, and reading the labels is also critical for parents. Esophageal atresia with tracheoesophageal fistula. Here, the proximal esophageal segment terminates in a blind pouch, and the distal segment is connected to the trachea or primary bronchus by a short fistula at or near the bifurcation. If you take a look in your textbook, you're going to see quite a few different pictures there's quite a few different versions of this particular defect. So please feel free to take a look at those. Approximately 50% of the cases of esophageal atresia with TEF are a component of VATER or VACTERL syndromes. And please note, these are acronyms that describe multiple anomalies. So please read through these in your textbook. I'm not going to go through every single anomaly. Know that presence of polyhydramnios, which is an accumulation of 2,000 milliliters of amniotic fluid prenatally, is a clue to the possibility of esophageal atresia in the unborn infant. This is a surgical emergency. So here you would see excessive salivation and drooling, the 3 C's of TEF, coughing, choking, and cyanosis. Also, we would see apnea, increased respiratory distress after feeding, and abdominal distension. Preoperatively, so they will have suction for the esophageal atresia continuously. They'll be supine with the head of the bed elevated at least 30 degrees. They'll be given IV antibiotics and fluids. They are NPO, and we want to prevent aspiration. So this typically has a few surgeries. The first surgery is they want to cut the fistula and then create a gastrostomy tube for feeding. They will be given IV antibiotics and fluids, and then even possibly TPN. The second surgery, they will do a reanastomosis of the 2 ends of the esophagus. Generally, gastrostomy feedings start within 5 to 7 days, and then if this is tolerated, then they can very carefully start oral feedings on days 10 to 14. Oral feeding is usually begun very carefully with sterile water, and we need to observe for any kinds of signs of choking or airway obstruction. So if we see an anxious expression or tachypnea, we need to pay attention to that. Post-operative care basically is the same for any other kind of abdominal surgery, with the exception of what I just mentioned. Follow-up, you want to teach parents gastrostomy tube feeding, signs and symptoms of infection. They are at increased risk for GERD, so parents need to pay attention to signs and symptoms of that, and also monitoring for aspiration. For the child or the infant who requires esophageal replacement, non-nutritive sucking should be provided with a pacifier. Infants who are on NPO status for an extended period of time and have not received oral stimulation frequently have difficulty eating by mouth after corrective surgery, and may even develop oral hypersensitivity and feeding aversion. So please, it is very important to get that sucking stimulation even though they're not able to eat. Remember Freud, that oral gratification is very, very important. Anal rectal malformations. Here, there's all sorts of different malformations that we can see here. And basically, it's malformation without an obvious anal opening. They may have a fistula from the distal rectum to the perineum, or even into the genitourinary system. So the diagnosis, basically there is an absence of innateness or rectal patency. So there is no meconium within the first 24 hours. They may actually have stool in the urine. They may have ribbon-like stools. An ultrasound and or a lower GI series will confirm the extent of the problem. Treatment is a reconstructive surgery. They can do a posterior sagittal anal rectoplasty. This may be done after a temporary colostomy after a couple of months. A primary laparoscopic repair without a colostomy for some anal rectal malformations is being used successfully. So nursing, really we need to observe for meconium on all newborn infants. Preoperatively, IV fluids, NG tube feedings, or I'm sorry, not feedings, NG tube to intermittent suction, good strict INO, no rectal temps, and then we want to give parents all of this information regarding the surgery. Postoperatively, monitoring vital signs, hemorrhage, pain, wound care. A few days later, monitoring for infections. Bowel sounds, typically they will be positioned sign lying or prone with the hips elevated or supine with their legs suspended at a 90-degree angle to the trunk. And this will actually help to decrease the pressure on the suture line. Once stable with bowel sounds, a clear liquid diet may be begun, and then they can progress to their regular diet. Again, these children often initially have a colostomy, and parents need to be taught colostomy care. Continence may not be achieved at the typical age, if ever. Know that they may require daily bowel irrigations and need support and reassurance. Failure to thrive. This also is not in your GI chapter. This is in chapter 10, starting on page 323. So this is a growth failure, and this is a sign of inadequate growth resulting from an inability to obtain or to use calories required for growth. We used to use the terms organic and non-organic failure to thrive, but really that's just too simplistic because most cases of growth failure have mixed clauses. So now we talk about it more according to its pathophysiology. So failure to thrive can be caused by inadequate caloric intake. So possibly they are not making the formula properly. Neglect can be an issue. Food fads, maybe they don't have enough food available. Breastfeeding problems, behavioral problems affecting eating, central nervous system problems affecting intake. Inadequate calorie absorption, so possibly food allergies, malabsorption syndromes, pyloric stenosis, GI atresia, inborn errors of metabolism. And then third is excessive caloric expenditure. Do they have hyperthyroidism? Do they have cancer, congenital heart disease, chronic pulmonary disease, or chronic immunodeficiency? And then defective utilization. So genetic anomalies such as trisomy 21 or 18, congenital infection, or metabolic storage diseases. As I mentioned before, the previous classification is really just too simplistic. Please note that poverty is believed to be one of the greatest risk factors for failure to thrive in developed as well as developing countries. Nearly 20% of children younger than 4 years live in poverty and are unable to obtain adequate food on a regular basis. The primary management is aimed at reversing the cause of growth failure. Therefore, an assessment of the child, the family, and environment is crucial. The goal is to provide sufficient calories to support catch-up growth at a rate of growth greater than the expected rate for the age. Diagnosis, if it is acute, the weight but not the length or height is below the accepted standards, usually below the 5th percentile. If failure to thrive is chronic, both the weight and the length or height are low. This will indicate an ongoing malnutrition. Perhaps as important as the anthropometric measurements is a complete health and dietary history, including perinatal history, physical examination for evidence of an organic cause, developmental assessment, and family assessment. Dietary intake history, either in the form of a 24-hour dietary recall or a history of food consumed over a 3 to 5 day period, is also essential. So nursing care, the goals in general are correcting the nutritional deficiencies and achieving ideal weight for height, providing adequate calories for catch-up growth, restoring optimum body composition, and educating the parents or primary caregivers about the child's nutritional requirements and age-appropriate feeding methods. Providing a positive feeding environment, teaching parents successful feeding strategies, and supporting the child and the family. These are all essential components of nursing care. You want to have an accurate assessment of the initial weight, height, and then do daily weights. We also want to record all food intake that is mandatory, and then document the child's feeding behavior as well as the child-parent interaction during feeding. When the child is being fed, we don't want them to be distracted, and we want it to be a positive environment. So if they are being bottle fed, the parent should be looking at the child's face and making sure there is good bonding present. So that completes our topic for today. Please make sure that you watch the other videos that are due this week. Thank you.